All right, so if you guys want to introduce yourselves, and then you can go get started.
So, hello everyone. I'm Anna Butcher. I'm the Urgent Family Response Coordinator for Behavioral Medicine. I'm going to go over a bit of background and then I'm going to pass the presentation to Rose and Katie, and they're going to cover their pilot project for the initiative.
Hi, I'm Rose Heater. I was one of the interns implementing the professional interaction coaching and de-escalation training. I just graduated with my MSW and accepted a position as a consult therapist at Healthy Minds.
Hi, everybody. I'm Katie Lawson. I'm also a MSW candidate from WVU. I graduated in August, and I was also a part of the interns that were responsible for piloting this program with Rose and Anna.
Okay, so I'm going to cover a little bit about what professional interaction coaching is and what de-escalation training is for our purposes. Professional interaction coaching is a way to teach patients how to effectively communicate and strengthen relationships when interacting with professionals. And de-escalation training helps patients and interns understand how to use proven communication and body language concepts to diffuse a situation before it escalates. Next slide, please. Okay, so this need was identified based on observations of patient interactions with professionals and how those interactions could either negatively or positively influence their circumstances. We felt that giving them tools to communicate more effectively could be something that was beneficial and aid in reducing miscommunications to help them meet their goals through a more productive interaction. Okay, and then Rose, if you want to cover the pilot on the next slide.
Okay, so this is just our timeline. It was 12 weeks. We had 9 weeks of the PIC or the professional interaction coaching, and then 3 weeks of the de-escalation training. And we had the pilot start date and end date there. Okay, can move on to the next slide. And then I'm Rose, and you already met Katie. Um, we were the ones who actually implemented the program, and we did meet with Anna periodically just to kind of touch base on how things were going and reflect a little bit on the experience. Next slide. Okay. Methods of delivery, everything was virtual. It took place at the beginning of group therapy sessions with the COAT groups, the pregnancy and postpartum COAT groups. It was weekly, and each session for Katie and I was about 10 to 20 minutes. Usually it was closer to 10 minutes. We tried to keep it as short as possible. Okay, so as far as the way that we implemented the curriculum, we very loosely followed this mini lecture model. Um, it took a lot of flexibility. It was a small group, and it took a lot of kind of just thinking in the moment and on our feet and adapting and adjusting. So we really tailored each session to the group members' needs. There were no more than 5 members each session, and most sessions we had about 3 members. Um, So each session was a different topic. So for example, like one day was professionalism, another day was looking at, differences between nonverbal and verbal communication. Um, so my main concern with delivering this information was to deliver it in a way where I was not placing myself above them. And I was more, joining them. I was really concerned about this when I first started, when we first started implementing it. I didn't want to come across as if I was like lecturing them on something or like trying to teach them something. So we really tried to keep it more discussion based, in order to, kind of learn along with them. And we did learn along with them. It kind of helped refresh some things that we already knew. And then I learned some things that I didn't know already. So that was my main concern with implementation. Um, Let me make sure I've kind of touched on everything. So yeah, we did kind of loosely follow this like connection. So activate patients' prior knowledge and help make connections. We did definitely explain the importance, letting them know like why we were doing this, which was to help empower them really in their interactions with, CPS or with the legal system or even in doctor's appointments, things like that. Um, Teaching, so we did show them how to apply the content by demonstrating the skill. I'll go more into that shortly. Definitely super active as far as like letting the patients try out the skill. I think Katie and I tried out the skills more than they did. We did a lot of role playing. So we kind of let them critique us. And then linking, so showing the patients where they can use the new skill. And then again, a lot of this was discussion based. So allowing lots of time for questions, sharing personal experiences, that sort of thing. Okay, next slide. Okay, so as I said before, the techniques were tailored to each session. So we used quite a bit of picture prompting. For example, I pulled some images that surfaced around like beginning COVID times. It was, I think we just called it like an eyes activity. So it was faces with masks on, and you were to like only read their eyes. So like kind of trying to figure out what their eyes were saying, and having them guess what they were saying. And Katie and I were guessing along with them. So that's just an example of like one of the picture prompts that we used. And then, yeah, using some probes. Why do you think that? We use a lot of questions. Honestly, I think we probably started out each session with questions about their own personal experiences regarding the topic for that day. And it was easy to do that, especially in the setting, like they were getting ready to do group therapy. So the participants were really willing to share their own personal experiences without feeling too vulnerable, I think, because they had already had that rapport with each other and felt pretty comfortable. So that was really, really beneficial that we were able to, hear those experiences and like kind of provide feedback and they could ask questions. Instructor and participant storytelling. So that is kind of what I just said. So illustrating the concept with real life. I think we leaned more towards the participant storytelling than instructor storytelling. Reverse Socratic questioning. So having the group members ask questions and answer in a way that leads to the next question, and allows instructor to drive patient in the desired direction. So that just happened really naturally. It wasn't something that we really even had to think about. It just happened really naturally with the whole discussion based delivery. Um, Self-assessment, we did use self-assessment kind of throughout, but and Katie will talk more about this, but we did use a measurement for them to kind of assess their own comfortability with communicating in professional settings before and then after the training. So we did have like a formal pre-test and post-test. Making them guess, we use this a lot. So introduce the new material by asking an intriguing question, something that few will know the answer to, but should interest all of them. So accept guessing, this builds curiosity. We definitely did this with the 6 P's of professionalism, for example. We had them see if they could figure out what the 6 P's were, and they honestly guessed every single one. And yeah, they were super impressive. Like I wouldn't have known had I not had the information in front of me. So next slide. Okay, and then as I've kind of been emphasizing this whole time, is just keeping things really learner-centered in order to, again, kind of join them instead of coming in above them. So the learner-centered model fits well with adult learning due to autonomy adults often need. So these were adults. So of course that was super important. They were all very knowledgeable, have tons of life experience, all parents. So kind of making sure we were keeping things learner centered and making sure they had that autonomy was super important. Um, this model also allows and encourages patient engagement. They were all very engaged with the sessions, and as I mentioned, they were not afraid to be vulnerable and share their personal experiences. Um, this learner-centered model puts patients' experiences first and gives them ownership over the content. So that just sort of reemphasizes what I've been touching on, and then avoids a focus on being too scholarly and allows patients to lead when appropriate. Again, these are different ways to say the same thing. So allows for brainstorming as a group, and then allows for use of real life scenarios needed for proposed content. So I will say we very much kept it learner centered throughout the entire implementation. Next slide. Okay. So the curriculum, again, Anna created the curriculum. It was really nice to already have all the information there and then just be able to kind of tweak things and come up with some creative ways to implement the information. So it did utilize that mini lecture model. We did consistently remain learner-centered, and we did consistently utilize those interactive techniques. And then we, after each session, reflected on how the sessions went, and kind of took note of like things that maybe we needed to touch on next time, or things that we needed to do differently, or things that went really well, so that we could, continue to remain learner-centered throughout the whole implementation. And
All
Katie's
right.
going to do the next part.
So the outcomes. So when we initially started this project, this was like a really interesting scope for me because prior to my internship, I also I was involved in the CPS realm. I worked with a foster care agency, so I saw a lot of these instances where bio parents were like getting essentially like steamrolled by these like professional interactions, and I saw the need firsthand. So this really gave me a unique perspective moving into this. And so the outcomes for this was to to really equip the participants with the confidence, the skills, and the knowledge of to how to kind of embark on these like professional interactions and how to de-escalate and how to effectively advocate for themselves, especially with this being such a vulnerable population. A lot of them do have past trauma, are do have like cognitive limitations, do have um, less adequate education and things like that. So this program essentially uh, provides them with these skills to where they can recognize and apply these skills to advocate for themselves and de-escalate situations that are like highly emotionally driven situations. Next slide, please. So one of the things that Rose brilliantly came up with was altering the self-perceived communication and competence scale. So this was already a valid, like pre-existing scale. And what Rose did is she like tweaked it and kind of like made it more applicable by changing the verbiage to uh, make it more so based around professional interactions, um, because essentially this assessment tool is essentially used for other interactions such as like family members and friends and colleagues, coworkers, things like every different type of relationship. So that's like what this assessment is typically used for, but we tweaked it to only kind of like look and gauge around like the more professional realm. Next slide, please. So as you can see, this was the outcomes of the pre and post test. Initially, we had 5 pre-tests given. However, once the project was over, we had 3 participants complete the whole entire thing. So basically, what our pre and post test looked at was their competency and their perceived confidence in reacting and speaking and engaging with the public, group, strangers, acquaintances, and as you can see in the very bottom, we really emphasized the professional realm, and we looked at that. And if you look at the pre and post test results on all 3 participants, you see that like there is a definite and significant findings that this was effective. Next slide, please. So the results and limitations. Overall, as you saw in the last slide, it was successful as evidenced by the pre and post test scores. Several participants also stated that they found this program helpful. We also used I'm horrible at pronouncing this, Qualtrics survey afterwards, where they also got to complete the survey, but also they had a chance to really like spell out like, you know, like what they really liked about this program, what they found efficient, what they liked, things like that. And all 3 of them stated that this program was helpful. Some of the limitations were that this was obviously a small sample size. Altogether, we only had 3 participants consistently throughout the whole program, um, which kind of depended on like who attended that group that week. So there was already going to be some like inconsistencies and stuff like that, especially when looking at like the COAT program. Another limitation was inconsistent attendance, as previously stated. And another limitation is that we didn't measure whether or not they retained the content. Like we didn't do quizzes or anything like that. We just solely based this on self-report and like their perceived confidence, like whether or not they felt better after this course. Um, Next slide, please. And so this is some of the feedback that we've received on their survey. One participant said the review of certain areas in which I need to remember when using proper communication was really helpful, especially when looking at like the text techniques that Rose and I demonstrated and role played and used. And another participant also stated that everything was very helpful, and another what like basic answer was very well done, thank you. So we received some feedback that was more detailed, and other was just more vague and appreciative but vague. Um, Next slide, please. So from my experience, um, I personally enjoyed how this program accommodates different type of learning, because as I said, this is a vulnerable population, and kind of what Rose talked about earlier, kind of having to meet them where they're at and really watch and monitor like the way information is presented to kind of not present it in a way that's lecturing. And for me, one of the things that gave me anxiety was that I don't have that much of a like a teaching experience. So one of the things that I really enjoyed from this is that Rose and I really made this more so more of a discussion based. Um, but we also implemented different things to accommodate different styles of learning, such as role playing. We also did, Rose presented different types of videos where they could watch it. So it's very like visual based, to accommodate those who don't have that great of like reading comprehension or things like that. So we try to like meet everyone where they were at. Um, Another things that I liked was that the lessons were already pre-made and pretty vague so that we could tailor them to make them applicable to whatever our participants were going through, and kind of just build on that, to kind of give real life examples as to the content that we were teaching so that there's a better chance of retention. And I really enjoyed watching each other build interactions with one another and kind of have them answer questions, but then have other people in the group answer their questions. So I really liked watching them become more confident in themselves and also finding ways to help others. One of the things that I really enjoyed is that one of the main modalities that Rose and I used in this was role play. Um, and so I would like take on the role of like what not to do, and then Rose would be like what to do, and we got to model those. And then they would give us their feedback on what they liked about certain things, and like they could critique us. And sometimes I would just go into it and we wouldn't even explain like this is what not to do. We would just go into a role play and be like, okay, what was successful and what was not? And they were able to identify the things that were not successful and the things that were. Next slide. So does anyone have any questions?